go back to the early setting.
Okay.
DB11, T-DXd, taxane, Perjeta, Herceptin in the neoadjuvant setting,
Okay.
or T-DXd in the high-risk residual disease setting. ILD and other toxicities are going to be very important for that patient population because that is a population you could cure. And so we have a lower threshold for death
Any risk.
or even debilitating toxicities. How are you going to manage those toxicities, or how are you going to follow those patients to make sure that you address them when they happen early?
Yeah, so in DB11, there were mandatory CT scans, and they were every 6 weeks, so every 2 cycles. And, you know, that was, you know, there were the 2 arms. They got the arm that got 4 and the arm that got 8. And so you were really doing a couple CT scans for that arm that got 8. Now, that one's not moving forward.
Which we don't do in early breast cancer.
We do not do
Right.
CT scans in early breast cancer. You know, I was really impressed by the DB11 data of the 5% ILD rate and no fatal cases. So I'm kind of intrigued to actually see what comes in the label of that, whether there are scans recommended or not. Because if we move forward with that 4 cycles, really it's 1 scan. It would be 1 scan at the midpoint, right? The 2 cycles in, and then they're kind of coming off anyway, right?
Yeah.
So I don't know. I haven't completely decided about that.
I mean, you could do it based on symptoms.
But
That would be 2.
But I think that's always been the advantage of trastuzumab deruxtecan, is that you're really trying to do the CT scans to find it before anybody has symptoms, right?
Right, and that way you can potentially, at least from the metastatic data, you can potentially re-challenge if it's a grade 1.
Yeah.
If
Would you re-challenge somebody
in the early setting?
neoadjuvant setting?
I would be for the 4 cycles. It's 4 cycles.
Yeah.
Maybe.
Okay.
Because if we can get it to resolve, so you incidentally found it, it's grade 1, treated or not treated, it resolve. Depending on the burden of disease.
I treat them all.
You treat them all with steroids, correct? Yeah. I treat them all too. And because they respond faster too.
And plus I want to get rid of it so we can get back on treatment.
Yeah. And so I would consider it, because then you have to switch to the other regimen. Because what are you going to do then? If you only give them 2 T-DXd and now they have grade 1, grade 2 ILD. Well, grade 2 ILD, there's no.
Go back to TCHP and then do DB05 on the back end if they didn't get a PCR?
Do you do 6 of TCHP? Or
We're
do you
completely out of the data-free zone now.
I know, but that's what's going to happen in reality. Does the T-DXd count for 1 or 2 of the cycles of TCHP?
I just do 6.
I would just do 6.
Because we're doing 8 cycles of something in the other regimen, right?
Yeah, I would probably just do 6.
Yeah.
Well, yeah, and then you wouldn't have to do the Taxol, Perjeta, Herceptin. So then, if the patient, so DB05 now, in the adjuvant setting, are we doing, because this is longer treatment of T-DXd, are you then doing Q6-week scans, or are you going to depend on the FDA to guide you?
I mean, I think we should take a little bit closer look at what we really saw there in terms of ILD. I think we are going to have to do scans for sure. And that's because the rate was over 10% and there were fatal cases. And so we need to be looking for those. So yeah, we're going to be scanning. I think it's just an issue of how often.
That supports your DB11
I know.
preference.
I know. Sometimes there's a method to my madness.
Sometimes there's a method. And so neuropathy, hair loss. With T-DXd, there's the risk of alopecia for some patients. In the adjuvant setting as compared to TDM1, which doesn't have alopecia, does that sway you left or right?
You know, I think in the adjuvant setting it doesn't, because all of our patients have had alopecia to AC, THP, or TCHP, right? So alopecia at that point with residual disease when they've already lost their hair is really not a big issue.
But you're continuing it for another into a year.
Oh, I don't know. Once patients have lost their hair, it's normally not as big of a barrier there. It's the having to lose your hair when you have a full head of hair.